Greetings, everybody. I'm Raidah Gangji, and it's truly an honor presenting as part of Diabetic Food Awareness Week 2024 in the Africa Region Congress. Today, I'll be presenting on a critical topic, antibiotic stewardship for diabetes-related food infections in resource-limited settings, with a particular emphasis on Africa region. Before I begin this presentation, I'd like to thank DFOod International and Diabetes Awareness Week for giving me this opportunity. I'm from Dar es Salaam, Tanzania, which is located in the Eastern African region, and we are homeland to Mount Kilimanjaro, Maturuni Falls, Serengeti, and Zanzibar Island. Welcome to Tanzania. Karibuni sana. So, before I begin this presentation, let's start by reviewing our objectives. First, I aim to highlight a cost-effective, sustainable approach to antibiotic stewardship for managing diabetes-related food infections in resource-limited settings. And I also aim to explore the benefits of using gram-stain-based methods to enable targeted antibiotic therapy in combating antimicrobial resistance. Diabetes-related food complications impact up to 25% of people living with diabetes mellitus during their lifetime. Shockingly, these account for up to 60% of lower limb amputations worldwide. Diabetes mellitus contributes significantly to community-acquired and healthcare-associated orthopedic infections, and this is true for both resource-limited and resource-rich settings. Given these alarming statistics, our focus on targeted approach to managing diabetes-related food infection is imperative, essential, and should be timely. In resource-limited settings, managing diabetes-related food infections comes with a unique set of challenges. One of these is the most pressing issue is limited access to essential diagnostic tools. Often, there is little to no availability of culture and sensitivity testing, which are critical in identifying the specific bacteria causing the infection. Without this vital information, clinicians are left with limited options and frequently rely on broad-spectrum antibiotics. While broad-spectrum antibiotics can address a range of bacterial infection, they're not always the best option. Broad-spectrum antibiotics contribute significantly to the rise of antimicrobial resistance. An interesting analogy used to describe this dilemma is the Spartacus problem. In history, Spartacus was a leader of the slave uprising during the Roman Empire, and his strength and courage was legendary. At one point in history, when the Romans captured the Spartacus army, they demanded that Spartacus reveal himself, but his soldiers were loyal to him. The Romans were unable to identify the real Spartacus among the thousands of army men. So the Romans took a drastic and unimaginable action of executing all 6,000 captured army men from the Spartacus army. So, I ask you all, are we treating diabetes-related food infections like the Romans dealt with the Spartacus uprising? Kill all in hopes of killing one? Just as the Romans could not distinguish Spartacus from his followers, we struggle to differentiate between infection that needs strong, specific antibiotic treatment and those that don't. I'd like to thank Dr. Stephen Swanson for his team at Tiny Feet Big Steps for this great analogy. This approach has serious consequences. Non-targeted treatment of diabetes-related food infections often mean that clinicians have to rely on broad-spectrum antibiotics without knowing exactly which bacteria they're targeting. This approach has its drawbacks. Rather than pinpointing a specific infection, it tends to increase the presence of MDR bacteria, multi-drug resistant bacteria. And this resistance leads to a secondary issue. An increase in MDR bacteria contributes to the challenges of antimicrobial resistance. And these challenges translate to a subsequent worsened patient outcome, increasing morbidity and mortality, which calls for the need of antimicrobial stewardship. We can slow the progression of resistance, improve treatment, and ultimately provide better care for our patients. So we conducted a little literature review focusing on publications which emphasize on antibiotic stewardship in managing diabetes-related food infections. And we found that the utility of bedside point-of-care gram stain lies in its ability to provide quick, simple visualization of invading bacteria right at the patient's bedside. This allowed clinicians to identify the bacterial-gram reaction, which can serve as a foundation for more targeted, semi-preemptive antibiotic treatment. In other words, even without full lab support, gram stain can provide clinicians with a semi-targeted approach to therapy. This approach is a practical form of antimicrobial stewardship. It helps reduce the use of broad-spectrum antibiotics, which can lessen the development of AMR. It's cost-effective, accessible, and supports antimicrobial stewardship, improving patient outcome in resource-limited settings. So when it comes to point-of-care gram stain, there are both advantages and limitations. Starting with the pros, one of the key benefits is that gram stain it allows us to narrow down the gram reaction of bacteria. However, the challenges lie in the risk of missing core bacteria in polymicrobial infection, which is true in diabetes-related food infections, as gram staining may only reveal the most dominant bacteria, and interpreting these results require a trained lab personnel, which are often unavailable in lower-level healthcare settings. So using this information, my team and I devised an easy algorithm which simply visualizes the pathway of using point-of-care gram staining for diagnostics and treatment. So upon diagnosing a diabetic food-related infection, a deep tissue biopsy is performed with subsequent steps depending on the availability of lab. If facilities are available, a culture and sensitivity is done. However, if the facilities are not available, a point-of-care gram stain is done. This is followed by a clinical assessment of the patient, which further categorizes the infection into either mild, moderate, or severe. This categorization further guides us in the choice of antibiotics, whether oral or IV, and the duration. After 3 to 5 days, treatment effectiveness is evaluated, and if clinical response is positive, we continue with empirical therapy, but if the response is poor, antibiotic treatment is supposed to be adjusted based on the latest gram stain or sensitivity results. This brings us to our next question: which antibiotics? The WHO released the AWARE Antibiotic Guide, which is a great tool that would help us choose our antibiotics. The AWARE framework categorizes antibiotics into 3 groups: the access, the watch, and reserve. And we can personalize this according to our countries by using our local essential medicine list. This algorithm is from the International Working Group of Diabetic Food Consensus Guideline, which is slightly adapted. So after the classification of diabetes food-related infection, for example, mild or grade 2 infection, first line access, oral antibiotics can be used, while for moderate or grade 3 and severe or grade 4 infections, which involves a more intense therapy, IV access antibiotics can be used. If after 3 to 5 days of treatment, patient shows a good response, we continue with our chosen antibiotics. However, if the patient's response is poor, we adjust to the watch or reserve antibiotics according to the WHO framework. This approach helps us target specific pathogens effectively while preserving the stronger antibiotics for more severe cases, supporting the antimicrobial stewardship and reducing AMR. So the key takeaways of the presentation are: while not optimal diagnostic method, gram staining is a valuable approach in resource-limited settings. It reduces the reliance on broad-spectrum antibiotics, mitigating AMR, resulting in better patient outcome. So advocating for the adoption of gram stain is a resource-efficient step towards a full antimicrobial stewardship. Thank you so much. My sincere thanks to Professor Abbas, Professor Iker, and Dr. Masood for their invaluable contribution and support.